So I'll kick off with one of the questions here. It doesn't say exactly who to, but I was told by my consultant that if you change to a new drug, for example, nilotinib to dasatinib, that you can't go back. Can you please explain why this is? Thank you.
Me? I don't think that's right. There are some patients, not many, but there are some, who don't have excellent responses with one drug, who then rightly need to switch to another drug. And what can often happen is that there's a decent response to that second drug, and then that's lost. So, there's a need to switch to a third drug, which in this case might be nilotinib to dasatinib. Let's say that in a year's time that patient gets a side effect on dasatinib. There's no reason why the whole rota can't be repeated. And I've certainly had patients who've been going for many, many years, but we have to keep changing the drug every now and then. So it's not perfection, and no one's going to do a study on this sort of thing. And this is the sort of patient who presumably is not suitable for even thinking about a transplant. But I don't see anything wrong with going around the houses in that sort of way.
Is it on? Yeah. Professor Clark, two questions quickly. For those people who were on the DESTINY trial and have been monitored for 2 years, no longer on the drug, are they cured? That's the first question. And the second question is, since DESTINY is now closed, what opportunities are there for people who fulfill the DESTINY criteria but can't reduce to half dose or come off completely within the DESTINY trial?
Yeah. Are people cured? Depends what you mean by cure. The only sure way that you know you're cured is that you were run over by a bus aged 87, and therefore the CML operationally was cured for the last, 40 years or something. So it's very difficult to be dogmatic about cured. John Goldman used to talk about operational cure, and it's a very good word because what may be happening is operational cure, that people are off treatment, the PCR may be detectable even if it's very low, so you can't say this is true cure, but operationally people are cured. Operationally, people are never cured of chickenpox because the chickenpox virus hits us when we're children, usually, but it never goes away, and in some cases it gets reactivated as shingles. It's the same virus. So we're never actually cured of chickenpox, even though no one really worries about it after a very young age. So it may be a little bit like that. So semantically, possibly cure is not the right word. Morally, it is. For people who have come off treatment and are many years off, and the chances of the disease coming back in a way that needs treatment is really, really remote. Yes, opportunities for more recent patients. This has obviously cropped up a lot because the trial closed in 2015. And I think the right advice is that because the results are actually quite good, to follow the recipe. So what we've done locally, and I know colleagues have too, is to go on to half-dose treatment for a year, and if all's well, to stop. Probably if we were running the trial again, I don't think we'd do the PCRs quite so frequently, so that's sort of good news. Because other than that first 6 months, which is important. But no, I think I would wind down in much the same way.
Thank you. Any more questions from the floor? Back there, thank you.
Hi. You mentioned that the DESTINY trial had more successful results than some of the other trials around Europe, etc. Do you think that's down to the fact that you reduce the dose first and then come off,
Yeah.
rather than coming off straight away?
I think almost certainly yes. To be strictly scientifically correct, we should have treated some patients with half-dose treatment and the others just straight stopping in the same study. But that would have meant twice the number of patients and twice the cost to get the same answer, essentially. But we've looked at it quite carefully and also, of course, talked to the Euroski people who've run the European version, who are essentially friends as well as colleagues. And I think everyone's agreed that the only real difference between our patients and our results is that initial year of half-dose treatment. Why that is making a difference is really very interesting. What I can tell you is that even with half-dose treatment, changes are happening in subtle things like protein expression in the cells generally, not just the leukemia cells. Leukemia cells, of course, are not very numerous, but in the normal cells, there are changes that are happening. So the body is gradually adapting, even on half-dose treatment, to the reduction. So it's not just that people are probably having too much treatment and just excreting the excess, like might be the case for, I don't know, vitamin C or something, which is actually what happens. With imatinib, it is actually, at 400 milligrams, it is doing something that is rather less at 200 milligrams. We've also looked at whether some of those changes correlate with some of those side effects that I talked about in the withdrawal syndrome, and we can't seem to easily match that. I think I may have mentioned that. So yes, and the other thing that might be possible is that there's some subtle effect happening in the way the very early leukemia cells are sitting in the marrow with half-dose treatment. Maybe they get a bit more active and they come out of hibernation, and then the imatinib's still there to go, or whatever drug is still there to clobber the cells, so we get a better result. And there's potential to look at that because a number of patients in the Destiny study were kind enough to donate marrow at the trial entry, and even in some cases when the disease recurred. And they're stored away in Professor Copeland's fridge and maybe coming out soon for a much more thorough analysis, though that's been waiting for some newer techniques to look at as well.
I came off imatinib for 6 months 2 years ago, after being taking it for 8 years, but had severe skeletal problems and I had to go back on the full dose. How long should I have given it for any symptoms to ease, or would naproxen have helped me with my bones?
There's no right answer, really, because you're you, and it's what suits you. I can tell you a story about a patient of mine who was a very fit and tough man, retired at 65 or so as a international lorry driver, never had an illness in his life, and his his pastime was going fishing. So there was a lot of this sort of action, casting. I'm sorry if any of you are fishermen, but this sort of action, which involves quite a lot of shoulder energy and probably some back energy as well. And he found he couldn't actually do that when he came off treatment as part of Destiny. And that was for him a big deal. There's a tough man, and for him that was a worry. But he just soldiered through that, and after about a year he was out fishing again. But I've certainly also looked after a lady, perhaps more like yourself, where she felt that the side effects were unacceptable and she'd rather go back on treatment. So it's different personalities. If you were prepared to persevere, I suspect the symptoms would have got better. But as I said to one or two other people, and may have mentioned in the talk, maybe some of your symptoms were just the fact we're all getting older.
Thank you.
My own view is no. Naproxen doesn't usually help. If people are really in trouble, the only thing that really has helped is steroids, but that's my own impression. I can't say it's part of the study. Mm-hmm. Certainly worth a try, but one would be a little bit less optimistic. Yeah.
All right. I think we'll stop the questions there because there's another chance for questions from the floor, or I've got another question here at the end session. So I think Mari's going to sort of introduce you to where the breakout groups are going to be and how to make your way to those.
Okay, so there are 4 breakout groups. There's going to be there's 4 separate sessions. Each session is going to run twice for half an hour. You're welcome to go to 1 session, 2 sessions, or no sessions. Maybe go and have a coffee. It's up to you. The sessions are staying in this room is going to be CML in childhood with Dr. Rao. In the, I think it was the William Penn room. David is going to do the carer session, so that's for carers only, no patients, no medical staff, no nurses allowed. It's a closed session. Then the other 2 sessions, I'm going to take a session on stem cell transplant in the Elizabeth Fry room, which is downstairs where some of you had lunch, and the William Penn room's down there as well. And then the final session is the pregnancy and fertility session that Dr. Milošević is going to take in the George Fox room, which again is downstairs. So the only session staying up here is the CML in childhood session. So give everyone 5 minutes to move around and get to their session. Sessions will probably last 20 to 25 minutes. There might be some chances for general discussion within the sessions as well. We meet back here at 4 o'clock to have some final questions and close the meeting.